Good afternoon. I would like to introduce Dr. John Burford from University of Nottingham. John obtained his veterinary degree from Cambridge University in 2001. He completed a PhD at the Royal Veterinary College in Ortopedic Biology and then undertook a residency in equine surgery at the University of Liverpool. John is currently an associate professor at the University of Nottingham. He's a recognized specialist in equine surgery and one of the youngest fellows of the Royal College of Veterinary Surgeons. John's research interests are the socioeconomics and welfare of working equids and also equine colic. Enjoy.
Thank you. If I'm speaking too fast or not clearly enough, please just let me know. So I'm going to talk to you about some of the research that I've been doing. Colic is a very important veterinary condition of horses. What I'm going to talk to you about this evening is what we actually do during colic surgery, and also how this is clinically relevant. So one thing that I'm really passionate about is that making sure that what research is done in universities actually translate to being a clinical benefit, either to veterinary surgeons or to the owners of horses or to horses themselves. So colic, as I've said, is a big welfare condition in horses. In the United Kingdom, it is the most common reason for veterinary emergencies. So 1 in 3 emergency call-outs in the UK are to a horse with colic. It's also something that has a big welfare impact as well. So from research that we've done at the University of Nottingham, in the UK, about 1 in 6 horses, 18% of horses that have colic are critical, by which we mean that those animals are either euthanized, require intensive medical management, or they need surgery. So therefore, if a vet is called out at a weekend, there's a 1 in 3 chance that it's going to be to a colic, and there's a 1 in 6 chance that they will either be sending that horse into a hospital or euthanizing that horse at that moment. So it is a big welfare condition in horses. This is my girlfriend. She definitely has sleepless nights, worrying about whether her horses have colic. And from my perspective, my interest of colic came pretty much from the early moments that I was a surgeon. And I'm hopeless with names. I've forgotten her name already, but I can remember 2 horses' names. And the first horse was a horse called Pancho. And Pancho was a big cob horse that we have in the UK. And he came in late at night. He needed surgery, and I operated on him. And he was the very, very first horse that I ever operated on. And he had a type of colic that we call a sand colic. So it's a colic that happens when horses are normally kept in poor conditions with very small amounts of forage. And when they graze very close to the floor, they take in small amounts of sand, and that builds up in their abdomen. So I operated on that horse, and we removed all of the sand from its colon, stitched it back up, and Pancho survived, and he went home. And so at that moment in time, I was the best colic surgeon in the world, quite literally, because 100% of the horses that I operated on survived. Now, you can probably guess what's going to happen next, because the next horse that I can remember the name of is Squirrel. And Squirrel came in, and he had a type of colic that we call an epiploic foramen entrapment. And that's where the small intestine crawls through a very, very small hole in the abdomen of every single horse. And it's just one of those unfortunate events that happened. And I operated on Squirrel, and Squirrel actually went home. But Squirrel came in 6 days later with more signs of colic, and I had to euthanize him. And so that led to my research interest in looking at how common colic occurs after you tried to fix them in the first place. Because imagine from an owner's perspective, they've just spent maybe in the UK, it would be about 25,000 reals on a colic surgery. And the horse goes home and they think they fixed it and it colics again. So it's a lot of emotional investment. It's a lot of financial investment to try and end up with a horse that might still end up being euthanized. What I thought we'd do first is, for those of you that haven't seen what happens, I thought I'd just show you a quick video of what might happen during colic surgery. If I can. Hang on. Hang on. There we go. Okay. So we always make our incision in the midline. So this horse is on its back under anesthesia. The horse's head is over on the right-hand side of the screen. And so we're making an incision through the abdominal midline. And what we're aiming to do is make an incision through and then start being able to examine the horse's intestinal tract. So the aim is to try and get in. This horse is bleeding quite a lot, so we control the hemorrhage. And then we make an incision into the horse's abdomen. So this is going through right through the center between the muscle layers. So hopefully there's a good amount of fibrous tissue that we can suture back together later on. So we very carefully make the incision because obviously we don't want to damage any of the intestines on the other side. And the first thing we look for is an organ called the cecum. And the cecum is essentially what makes a horse a horse. So the horses have their hind gut fermenters. So they use microbes to digest their food in a similar way to ruminants. But instead of using 4 sets of stomach, they use their cecum. So this is the cecum here. It's about the size, it's about 35 to 50 liters. And it's a blind ending sac, which is essentially the same as the appendix in us, but much, much more well developed in a horse. And this is the primary site where microbial fermentation will take place. And what we do then is that, having found this point, which is the midpoint of the gut, I can then start to look at the small intestine. So I'm working forwards now. And what I've found is this object just here. And this is something that is one of the most common causes of colic in the UK. It's something that I suspect that you probably don't see very often in Brazil. And this horse has something called a strangulating lipoma, a pedunculated lipoma. And essentially, it's a ball of fat on a stalk, and it wraps around intestine and therefore constricts its blood supply. And when we're dealing with colic in horses, quite often we're dealing with the effects of something that's cut off blood supply to a region of intestine. So what I'm doing here is I'm just trying to find the stalk that this ball of fat is attached to. And you can see that that string is very tightly wrapped around that piece of intestine. So once I've identified that, I can cut that, and that's going to release this lipoma. And as I said, lipomas are one of the most common types of colic that we see in the UK. They almost always require surgery to correct them because they have obstructed this section of intestine's blood supply. So now what we have is that we have the necrotic dead piece of gut, and that is not viable. So that piece of gut has to be removed. So the next stage is to lay out all the gut. We can see this part is healthy, and that's called the ileum. So that's the very last part of the horse's small intestine. And in total, there's probably about 1.5 meters of intestine that needs to be removed from this horse. Now, most horses will have around about 15 to 20 meters of small intestine. And we know from experiments done during the 1960s and 1970s that you can remove around about half of a horse's small intestine and it will be absolutely fine. So we can remove 10 meters of this horse's gut and it won't have any problems at all. And again, that relates to the fact that the horse doesn't really need a small intestine in the same way that we do, and definitely not in the same way that a pig would do. Because all of the fermentation occurs in the back end of the gut, the small intestine can miss out on the small amounts of simple sugars that make up that horse's diet. So once we've identified which section of gut needs to be removed, we can then start to tie off all of the blood vessels. And then this is basically creating the situation where we can start to then remove that section of gut, suture it back together, and then hopefully the horse will make a recovery. So I've cut off all the blood vessels. You can see that this blood vessel now has been ligated down here. I'm doing the very last part just in here. And then once that's done, we can cut this section of gut out, and then we can start thinking about reconnecting the two healthy sections of gut. So that's going to be the next part, just in here. And around about, in the UK at least, around about half of surgeries that we do on horses will involve the small intestine, 40% will involve the large intestine. So now that I've cut that blood supply off, I'm going to cut through and be able to remove the two sections, now start to reconnect those two sections of gut. So everything on the left-hand side of the screen is going to be removed. And then those two ends, I'm then going to start repositioning so that I can suture those back together. And the majority of surgery that we do tends to still be hand sewn. We with suture material, we'll suture those pieces back together. So very carefully, I can reposition those, and then I can start to do the suture that's going to reconnect those two pieces. Now, this is quite a tricky part of surgery because we need to make sure that that connection is functional. So I can't make it too small because then food material won't pass through. I have to make sure that it is completely watertight so that bacterial contents don't leak out into the abdomen. So what we normally do is do this in 2 layers. Now that takes a little bit more time. It constricts the lumen slightly more, but it does mean that we have a much safer join between those two ends. So this is on the second part now. So I've done one side and I'm now starting to do the other side of surgery. Now it also is one of the things that creates problems for us. Because we've reconnected those two pieces of gut, they're not immediately functional. So one bit was nowhere near another bit 10 minutes ago. And consequently, those things have to recover during the post-operative period. So that's the repair that we have there. I'm just going to test whether material passes through that okay. But you can see we've now sort of restored a normal section of gut in there. What I'll also do is go back through the rest of the horse's intestine, just make sure there aren't any other problems. You can see that there's a very small lipoma just here. We can remove that. I'm going to examine the other parts of the horse's intestines. This is the small colon. So this is the very last part of the horse's intestine. There's a small lipoma on here, but otherwise it looks relatively normal. So we can just examine it carefully, find out if there's any problems, and then we can replace that. That's a smaller lipoma. You can see the stalk that wrapped around that piece of intestine on there. And then the final part is this. This is the horse's large colon, so the large intestine. It's about 2.5 meters long from end to end. And then I can put all that back together and that fixes it. So this horse did absolutely fine after surgery, had no episodes of colic at all. But what we need to do is understand exactly what's happening with horses in colic. So this horse has had surgery. Now what we need to be able to do is talk to owners about whether that horse is going to be fully restored to normal function or whether it's going to have any further problems. And what we know is that, unfortunately, further episodes of colic are the most common complication that we have after colic surgery. So we try and fix them, but they colic again. Now, we also need to know how common colic is in a normal horse. So are we restoring these horses to normal function, or are we causing them to have higher rates of complication than any other horse will do. And so what we need to do is we need to understand what the incidence of colic is in a normal population, and that's quite a difficult thing to estimate. But most estimates would suggest that the incidence of colic is between 3 and 19 episodes per 100 horse years. So if you owned 100 horses for 1 year, then you would probably have around about 5 to 10 episodes of colic during that year. If you had 20 horses, then you'd probably have about 1 episode of colic. So the way that we did this is that we did a very long-term study, and in total we collected nearly 3,000 years of survival data. So we looked at horses that had surgery, and then we followed them up. We contacted the owners, and we made them keep a diary of every single event that occurred during that horse's life after surgery. And in total, this was all performed at one hospital, University of Liverpool. Yeah. And during those 3,000 years of colic, of post-operative survival, we recorded 1,000 episodes of colic. That was seen by owners. And so if you look at the number of horses that have more episodes of colic after colic surgery, you can see here that 52% of horses don't have colic, but that means that 48% of horses that have a colic surgery go on and have at least 1 episode of colic again in their life. Now, they may only have 1, and that's it, and there's no problems at all. They may also have 1, and at that point, they're euthanized. So we don't know anything more about their recovery or their period or anything at all. So we looked at when this happened. The mean time to the first colic was around about just over half a year. And that was the mean time to the first episode of colic. The mean time to any episode of colic was a little bit longer. And then what I did was then did some multivariable statistical analysis to try and work out what the factors that influenced this instance of colic were. And the 2 most important factors were a specific type of way that we put the gut back together. So in the video that I showed you, that was what we call an end-to-end jejunal anastomosis. There's another type of thing that where if there's more of the intestine that's involved, then that very last part of the intestine is also compromised. We have to take the small intestine and put it directly onto the cecum. And that's called a side-to-side jejunocystectomy. And that was associated with a hazard ratio, so a multiple event or multiple risk of having colic of around about 2.2. So horses that have a side-to-side jejunocystectomy are around about 2.2 times more likely to have episodes of colic than a horse that has another type of surgery. The other major factor was having a second surgery. So that indicated that the fact that you're doing the surgery is compromising the horse to some degree. And if you do that again, obviously all of these horses had 1 surgery, but doing a second surgery compromises the intestine even more. And that leads to more episodes of colic again in the future. And when we look at these by a specific type of survival analysis that we call Kaplan-Meier plots, you can see this quite clearly and graphically. So the blue line is all of the other horses, and the green line is the horses that have our risk factor of incidence. So in this first graph, we have relaparotomy, and in the second graph, we have side-to-side jejunal anastomosis. And every single time the graph drops down 1, that's another horse that has an episode of colic. So you can see that normal horse or the other horses also have colic pretty regularly, but not as much as horses that have either of those 2 risk factors. Now, fortunately, those 2 types of events are actually quite unusual. So it doesn't tell us a huge amount about how we can reduce the risk of colic in all of the other horses that have surgery. So what we did, or what I did, is did further analysis to look deeper into different risk factors. So by doing careful statistical modeling, we can eliminate all of those horses that have side-to-side jejunal anastomosis or relaparotomy to try and get more evidence about the rest of the surgical population. And when we do this, we find that there are 5 risk factors that are associated with different types of colic, which is good because we can't do anything about the horse needing to have a second surgery. Sometimes we can't do anything about the section of intestine that's compromised. So we have to do a side-to-side jejunal anastomosis. But when we look at these other risk factors, we then start to get things that we can start to influence, and we can make positive changes to the risk of horses having colic again in the future. Duration of surgery, that's something that we can start to do something to improve. Total protein concentration is something that we can't do a lot about. Yeah.
The duration of surgery is confounded by the severity of the case.
So this is multivariable analysis. So we've removed that as a confounding factor. So this is even, so if you have 2 cases, one has severe pre-surgical parameters, the other doesn't, but they have the same duration of surgery, then that's how we can remove that as a competing factor. So we looked at competing, or I looked at competing risks, and I also did this by multivariable modeling. So all of those confounding factors have been eliminated. These are the remaining factors that stick within a multivariable model. Large colon volvulus is a specific type of colic. Crib biting, this is a stereotypical behavior of some horses that we could potentially do something to influence. And also, quite importantly, grass management, which if you look at the number, you can see that for these, well, certainly for duration of surgery, colon volvulus and crib biting, if they have that as a risk factor, you increase the risk of post-operative colic. If you manage a horse at grass, it actually reduces the risk of colic again in the future. So now we can start to give owners important information about how they need to manage their horse post-operatively. Again, we can see these as Kaplan-Meier plots. We can only do this easily for the categorical variables. We can do different models for the continuous variables. But you can see here for the grass management, whereas in the other ones, the green one is the one that has the worst outcome. For grass management, the outcome is actually better. So now we've got information that we can positively give to owners. Now, the other bit that I was really interested in was looking at when horses colic after surgery. So we've said that the background rate of colic is around about 5 to 10 episodes per 100 horse years. Now, if we look at this population of horses that has surgery, overall, for all the time that we follow them up, the incidence of colic is 36.5 episodes, so much, much higher. Now, the difficulty with that is this falling over time, or are we just killing the horses that are going to repeatedly colic until we eventually get to a point where we either have no horses left, or we've just got horses that actually have pretty small risk of colic at all. So if we look at it, if we start looking at it on a month-by-month basis, we can see that the rate or the incidence of colic is very, very high in the first year after surgery. But that rate of colic falls to a point where it's almost at a plateau. So if we look at that by time, and over a 100-day period, you can see that by the time we get to around about 3 years after surgery, we're nearly at the point where those horses don't have a higher incidence than the normal population of horses. Now, that's because of 2 things. One is that we've, as I've already said, euthanized all the horses that colic all the time. So we've removed them from the population. But we've also got to a point where time has just allowed all of those complications that occur immediately after surgery to get to a point where they're not compromising the horse any further. So in conclusion, we do know that 2 risk factors are by far the most important in terms of the risk of post-operative colic, but there are other things that will affect the likelihood of colic as well. Now, that's not where the story ends though, because as I said, I always want to make sure that the research that I do is relevant to the horse population. So if we start to use this information, we can then give owners a much better idea how they need to manage their horses in the post-operative period. So this then starts to give us information that we can start to use in a clinically important and meaningful context. Some of those things we can't do anything about. Horses having a large colon volvulus is the reason that they presented to us. That's something that's fixed around the horse. But many of those other things we can actually influence positively and therefore try and change the outcome of these horses. Now, one of the most important prognostic factors for any horse that has colic is the degree of systemic inflammatory response syndrome that the horse presents with. And that's quite closely related to whether a horse has large colon volvulus in the first place. That is the most critical and pretty much the most compromising presentation that a horse with colic can have. It's had that colon, so around about 3 meters of intestine, turning around in 360 degrees, compromising that entire abdominal organ, releasing all of that bacteria that's present in there through the compromised mucosal surface. And not only that, you've taken around about, well, you've certainly taken all of the blood that was in that colon at the time of surgery, and you've removed that from the horse's systemic circulation. It's a pretty devastating thing that can happen to a horse. But even then, if we remove those and we remove the effect of confounding from those, we know that all of the other signs and proxies of systemic inflammatory response syndrome are really important prognostic features. So heart rate, PCV, things that you can measure very easily will be good predictive parameters. And that means that we can measure those very simply and easily, and we can start to give owners meaningful information. If you have a horse with a heart rate of 100 and a packed cell volume of 60 and a total protein of 55, then don't give that owner a very rosy outcome. That horse is probably going to have a very, very serious lesion and has a very much worse chance of surviving than a horse that has a normal heart rate and other normal clinical parameters. We can also start to influence those by careful preoperative preparation. So we can give horses appropriate antibiotics, we can give them non-steroidal anti-inflammatories, we can potentially pass stomach tubes to make sure that we reduce those things that are going to compromise that horse even further. But ultimately, if a horse needs surgery, it needs to get surgery as soon as possible. We can also do things that are going to reduce the amount of surgical time. So by doing that midline laparotomy, we're trying to get into the abdomen as fast as possible. We can also make sure that we have the experience and the pre-surgical planning to be able to perform the surgery as quickly and appropriately as we can. Now, that midline laparotomy does give us some compromise. So it does mean that there are parts of the gastrointestinal tract that can't be easily accessible, and there are different bits that we can't quite get to. But even so, it gives us the best possible way of performing the best surgery that we can. But as I said, we need to make sure that we're doing things appropriately. So again, good pre-surgical planning, good surgical skills are going to reduce that time. So there's no point in making an incision the full length of the abdomen to repair something that we don't, we just need a small incision for, because that's just going to add to the amount of surgical time, and therefore the time that the horse is on its back, the time that the horse is having cardiovascular compromise because of the general anesthesia, the time that the horse is having compromise of its respiratory system, all of those things which confound and make the situation worse are going to be reduced. We can make sure that we do a thorough and systematic examination. So as I showed in the video, the first point that we start at is the cecum, and that allows us to make sure that we systematically examine the gastrointestinal tract rather than just reaching in and pulling out bits of gut, finding they're normal, throwing them back in again, pulling out another bit. We can make sure that we do things logically and make good clinical decisions. As I said, sometimes we have difficulties. So there are bits of the gastrointestinal tract that we can't actually get to. So that horse, the squirrel, had something called an epiploic foramen entrapment. Now that's actually above the horse's liver. So effectively, from a surgical perspective, that's way down deep in the bottom of the abdomen as far as we're concerned. There are bits that we find difficult to get to and remove. We also then need to start thinking about surgical improvements. So now, since Squirrel had his surgery, we can now surgically close the epiploic foramen. So we can actually do that because people have recognized that epiploic foramen entrapment is associated with very, very high rates of post-operative complication. So people have then developed surgical techniques to make sure that that isn't a complication for us again in the future. There are other parts of the gastrointestinal tract that just become physically difficult to do anything about, diaphragmatic hernias. And sometimes you can get other things that affect parts of the gastrointestinal tract that you can't get to. And in those situations, you just have to do the best job that you can. So consequently, we need to make important and clinical decisions. So that might be a decision about whether to remove a piece of intestine or whether to leave it in place. And again, good surgical judgment has got to be balanced against the risk that occurs. So people have tried to make objective assessments to how to assess gastrointestinal function. You can do things like injecting fluorescein and then examining the gut with the ultraviolet light to see whether it is appropriately perfused. The problem with all of those sorts of things is that they take time. And ultimately, it comes down to typically clinical experience often is the best way of assessing whether gut is viable or not. Generally speaking, it's far better to remove it based on the evidence that we already have. Relaparotomy is about the worst thing that can happen to a horse in terms of compromising it again in the future. So therefore, removing anything that you're not sure about is the right decision to make based on clinical evidence. So beforehand, you might have gone, oh, well, it might be okay. But if you were wrong, you need to reoperate on that horse. And the compromise that that horse suffers from is greater because we have the evidence to say that actually that extra 30 minutes of surgery time will compromise it far less than operating on that horse again in the future. We know, as I've already said, that we can remove a reasonable amount of the horse's small intestine. Because the horse is a herbivore, it doesn't have high amounts of fats or protein in its diet. We can remove 50% of the horse's small intestine and it will function absolutely fine. If we go beyond 50%, then it starts to suffer from something we call small bowel syndrome. It has protein loss and malabsorption, and they tend to have poor weight gain because they're not getting those simple sugars, fats, and amino acids from their diet. The type of anastomosis is important. We know that side-to-side jejunocostomy is a very bad risk factor, but quite often there's nothing we can do about that. If the ileum is compromised, we have to remove it, and that's a choice that we can't avoid in any different ways. But we can certainly choose the most appropriate anastomosis for the given clinical situation. And certainly there are things that we can do to more rapidly perform anastomosis in other situations. So automated stapling equipment will improve surgical time. We know that surgical time is a risk factor. So therefore, anything we can do to accelerate that process is going to lead to more positive outcomes for that horse. So stapling is a way that we can then start to speed up surgery. The disadvantages to it are cost, but the cost is balanced against the fact that the surgery is quicker. So generally we charge surgery by time. So if you save 15 minutes, but it costs you $200 more, then it might actually be positive. And this is the type of thing that we'll achieve with a stapling device. So you can see that inside this piece of tissue here, are around about 100 titanium staples. And it took me about 15 seconds to place that staple line. Whereas if I'd hand sewn that, I'd probably need about 40 individual bites of suture material. So that time that's going to take to do that is significantly greater. Now, I've said that large colon volvulus is one of the most devastating types of colic that horses get. Quite often, we need to make good decisions for those horses. And certainly, if any of my horses had a large colon volvulus, I would actually euthanize them. I wouldn't put them through surgery because the prognosis for those is pretty poor. So there are important things that we can advise owners on and to give them the information to make appropriate decisions for their animals. In some situations, it's possible to actually remove the large colon. So large colon resection is described. You can literally just anastomose those two sections up there. And horses actually can do okay. The difficulty is how sick they are at presentation. Because if they're really sick and you're trying to do that to them, then often that isn't a favorable outcome. But if you can recognize these horses in clinical practice much earlier, operate on them faster, then again, that's going to improve clinical outcome for that horse. But generally speaking, in the UK, we don't perform large colon volvulus very often. Now, if you go to the United States, where they have high concentrations of thoroughbreds, very, very close to absolutely incredible surgical facilities, where that horse colicking is going to be recognized within 15 minutes of it starting to colic, and it's going to be on a table within 45 minutes of it starting colic, then that becomes a very, very feasible opportunity. But in the UK, where generally it's going to take 3 to 4 hours before that horse presents at a surgical facility, that isn't possible at all. Final decision that we might have to make is how to close the abdomen. Again, based on time, it's far better to do it in 2 layers than it is 3. Just saves you another 5 minutes of surgery, and we know that surgical time is a risk factor. So consequently, we can use evidence-based medicine to very, very functionally change the outcome for these horses that we operate on. So by performing quite time-consuming and extensive longitudinal analysis, we can get evidence that is actually going to be clinically important to the patients that we operate on. This is a horse that I operated on. It's a thoroughbred racehorse, and that's it winning first time out after surgery. So horses can do very, very well, but we need to employ good clinical judgment to get to them to this point in the first place. Thank you very much.
Agora é um tempo aberto para perguntas durante 15 minutos.
The question is, you present in number of hours. How many clinical cases this corresponds to?
That was 3,000 hours of post-operative data, and that was obtained from 964 cases of colic. So that is the largest population of horses that's been followed ever in a single study.
So considering that the horse is an animal that eats walking long distance, and this affect the improving of the case of colic, do you know and do you approve some kind of monitoring system during the night when the animal is stabled, for example?
That's a really good question. There are some systems that are starting to become available. And in fact, I'm doing some research with a company that's trying to develop that. Now, at the moment, those aren't commercially available. There are monitoring systems based on CCTV and things like that. At the moment, it's an excellent question because we are trying to develop algorithms that will predict horses having colic. So there's a device available in the UK. Now, it's actually marketed for just seeing where horses go. It's a GPS tracker, but it also has accelerometers in there. Now, the difficult thing is creating the algorithms that are going to distinguish between normal equine behavior, just rolling and walking around a box, and colic behavior. So excellent question, and hopefully within a couple of years I'll be able to answer that.
Or perhaps we can do together. I mean, we had that's even better. We're very fast here, just quite.
In terms of cameras, yeah, that would be a great way of doing things. So again, there are systems that are available more specifically for monitoring horses, thoroughbreds especially, for foaling. But in the most part, those still rely on visual. So that if we can develop this device, then that will do exactly that. So yeah, hopefully it'll be more useful in the pre-surgical situation, because you're absolutely right. The difficulty is that horse that starts colicking at 2 o'clock in the morning, that then doesn't get found until 7 o'clock. Now, if you could recognize those signs of colic and send a message to your mobile phone to make somebody go and check whether those are normal signs or abnormal signs, that's going to hugely change the outcome for that horse. We know that the most important predictive prognostic indicator for horses and colic is systemic inflammatory response syndrome. And that occurs as a duration of time. From the moment that horse starts colicking, it's going to be more compromised. So if we can identify and operate that horse quicker, then that's going to improve its prognostics. Okay.
I'm curious about cribbing. Why cribbing should increase the outcome worse? What is your
so the theory with that is that I think we know from it's a risk factor for surgery in the first place and for colic in the first place. So it's not actually a risk factor for post-operative colic. It's a risk factor for any episode of colic. So, for example, taking epiploic foramen entrapment, a horse that crib bites is around about 65 times more likely to suffer from an epiploic foramen entrapment than a horse that doesn't crib. So it's not the fact that a cribber is more likely to have post-operative colic, but that's also because it was more likely to have pre-operative colic. So it's just continuing the same risk factor for colic in the first place. So why they colic? There's some good evidence to show that horses that crib or windsuck are much more likely to suffer from displacements. It's debatable how much aerophagia occurs, but probably there will be to some degree, and that's gas that occurs and builds up within the intestine then starts to move it to different places within the abdomen. So it causes the functional displacement of the large intestine. It causes the small intestine to migrate dorsally within the abdomen to put it in a closer apposition to the epiploic foramen. There is also an alternative debate about whether crib biting and windsucking is a stereotypy or whether it's a functional physiological need of that horse. So there is a theory that suggests that actually the cribbing is a consequence of an abdominal problem that already occurs. So there is something different about that horse's abdominal tract that manifests as crib biting behavior. So it's not the thing that causes the colic, that's already there, but the functional manifestation of the horse is that it has a physiological need to crib or to windsuck. There's even some evidence to suggest that horses that crib or windsuck may also have central nervous changes compared to normal horses. So people have looked at how crib biters respond to stimulus, and they do respond in a slightly different way than a normal horse would do. So there's some evidence to suggest that it may be a central change within the nervous system. It may be a change within the abdominal system. It may be that there just is a stereotypy and that causes changes in the gastrointestinal tract. So we don't know. But in terms of being a risk factor, it's not a risk factor for post-operative colic any differently than it's a risk factor for pre-operative colic.
I've been very interested in crib bite. We did some research in the 90s, and we did show that cribbers are quite different in terms of the beta-endorphin concentration. We checked and showed their differences in responding to nociception. We did a fair amount of work. But you mentioned about air going through. If I remember, there's I think the late 90s, the work from the folks in Bristol that showed that no air went through. You're telling me now that there's some evidence that air goes through in cribbing. Help me out.
So it is still a matter of debate. So you're absolutely right. There was a paper in the late 90s where they did fluoroscopy, and they showed that there was minimal aerophagia that occurred. There are other studies that have been done since then that actually show that there is an increased volume of air within there. So it's one of those things that we don't know. It isn't clear and conclusive one way or another. My personal belief is that there probably is, at the very least, some change in the motility of those horses. Whether that occurs because of the cribbing or after the cribbing is not very clear. There's definitely something different about those horses. And you're absolutely right. There's differences at a brain neurotransmitter level. There's definitely differences within the local neurological control of the gastrointestinal system as well. So you can look at differences in terms of gut motility. So whether that's centrally mediated or whether that's locally mediated, we're not entirely certain.
Do you have experience your case review for 2016 courses?
It was 1,064 episodes of colic amongst 964 surgical cases.
What do you think about nephrosplanchnic improvement and the case of a new case of disimprovement, and if you close this case after the second case?
So my choice would be, if a horse has 2 episodes of nephrosplanchnic entrapment, then I will suggest to the owners that we surgically ablate the nephrosplanchnic space. And now again, just in the same way, well, it's a much easier surgery than doing epiplate foramen entrapment, epiplate foramen enclosure. So my preferred way of doing that is a hand-assisted laparoscopy. I have tried doing it solely laparoscopically, but I find it much easier to make a laparoscopic portal and then do the actual suturing by hand and then do extracorporeal knots. But if a horse does 2 nephrosplanchnic entrapments, then I recommend that we do ablation of that space. And in general, certainly in my experience, I've had minimal complications as a result of that surgery. So I think it's perfectly viable surgical option.
We have no other questions. What do you think about to do a resection of a small
Nearly to
the... Really good question. So while I was at Liverpool, we changed our opinion of those. So the problem with the ileum is that it only has a single arterial blood supply. And consequently, it was felt that if there's any compromise of the ileum at all, there's likely to be a compromise of that blood supply, and therefore it's better to do a resection of the entirety of it. Now that leads, therefore, automatically to needing to do a side-to-side jejunal But we know now that that is one of the most compromising surgeries that we can do. So we changed while I was at Liverpool, and we changed to do jejunal ileal anastomosis more commonly. So given the choice, and if I'm confident that there's still reasonable viability of the ileum, I'll do a jejunal ileal anastomosis. So I will avoid doing a side-to-side jejunal if I can do. That's a really, really good question. The problem is, personally, I think that the majority of colic that we have is from the management of horses. Now, the problem is that we don't have the evidence of what the incidence is in a wild population of horses. Probably, they must get some colic. And they probably get colic towards the end of their life when, they've got minimal teeth left and they're going to about to die of malnutrition because, they have no teeth. They can't masticate their food. They're going to get impactions and things like that. But they're also probably going to get attacked by wolves and all sorts of other things before they colic and die. The colic that we see, certainly in the United Kingdom, is because of the way that we keep horses. We keep horses in conditions that their gastrointestinal system is not designed to deal with. A horse is designed to eat poor quality forage for 15 or 16 hours a day. We feed horses on, certainly in the UK, on grass fields that are designed for dairy cattle that have metabolic rates 10 times higher than a normal cow is going to have. We feed them twice a day with dried out forage, and we let them eat that in half an hour, and then we don't feed them for the next 8 hours. So everything we do in horses is counterintuitive for the way that the horse actually evolved. So a horse evolved 70 million years ago from a little deer-like creature called Eohippus, and it's designed to live on Mongolian steppes. It's designed to live in the Arabian Peninsula, and it's designed to move sort of 5 to 10 miles a day, eating pretty poor quality forage. Everything that we do is completely opposite to what we actually do with horses. So we create colic, absolutely. Now the difficulty is that it's hard enough to calculate the incidence of colic in a managed population. So in the last 25 years, there have probably been 3 good papers that looked at the incidence of colic. And the most recent of those was published in 2001. So there's 2 papers from 1997, 1 from 2001. And since then, for the last 17 years, there have been no good papers that have even tried to calculate what the incidence of colic is, because it's hard to do. You have to look at a lot of horses for a long period of time, and in an ideal world, watch them for 24 hours a day to find out whether they're suffering from colic. So that's hard in a managed population. So it's difficult to say that it's different in an extensively managed population. But my personal belief is it's got to be much, much lower. So to answer the question of whether we're going to ever get to a point that we get rid of it, no, we're going to get more, because we're going to put our horses through more. We're going to restrict their diet. We're going to compromise them even further. So no, it's a problem that's not going to go away. Definitely not.
Because I heard some people say something about the pounds. We create the acidosis.
Absolutely. We create the acidosis. We create the abomasal displacements. We do all of those things because we're pushing that animal in a way that it was never, ever designed to do. We're feeding them in ways that are completely unnatural to them. We have to give them all of those concentrates because functionally, there's no other way that we can get that amount of energy into them in order that they can produce 10,000 litres of milk a year. So we cause all of these problems. It goes down to breeding as well. We were talking with our earlier, breeding would do a lot to improve the orthopedic disease that we see in horses, but we want horses to run faster. So we're going to breed the ones that are best, not the ones that are genetically improved because they're going to be less likely to get osteoarthritis or less likely to get osteochondrosis dissecans, less likely to get recurrent loungeal neuropathy. We choose them because they run faster. We're not choosing them for the reasons that actually make them a more all-round better horse. Yeah. At what stage of pregnancy? Anytime. Obviously, towards the end of pregnancy, the colic is normally associated with imminent parturition. Generally speaking, in the UK, cesarean is normally performed on a dead animal, the dead foal, because by the time that you get to a point of cesarean, the aim is to save the mare. The foal is already dead at that point. Up to the age of about 9 months, I tend to not worry too much. So I would approach those in largely the same way that I would do with a normal case of colic. You're compromised significantly by, obviously, the size of the uterus. But certainly up to about the age of 8 months of gestation, you've still actually got a reasonable amount of room in the abdomen. So most of that fetal growth occurs in the last trimester. So up to that point, you've still got a reasonable amount of surgical access. Beyond sort of 8 and 9 months, then actually most of what you see in the ventral abdomen is uterus. So at that point, if I could do, and I felt that the surgical situation was appropriate, I might then consider doing standing surgical procedures, as long as I was reasonably confident about what I was dealing with. Now, obviously, if I felt confident that the horse had a large colon volvulus, which would be uncorrectable through a flank laparotomy, then I wouldn't do that. But if I was reasonably confident that there was something that I could correct through a flank laparotomy, then by that stage I would probably do that. So yeah, it depends on the clinical presentation. Yes, we often will do as a sort of management of trying to make sure that they don't abort, so to maintain pregnancy. Interestingly, progesterone doesn't have the same effects as it does do in other species in terms of management of mares, but I definitely would do, because I think you've got nothing to lose at that point, so I definitely would do. And also quite often we give them more long-term antibiotic therapy as well, just to make sure that there's no dysfunction that occurs between the placental barriers. So quite often we keep those on antibiotics for longer than we would do in a normal clinical presentation as well. The only thing I'd possibly do slightly differently in management of a pregnant mare is that I don't use xylazine. So in the UK, we have 3 sedative agents. We have xylazine, ditomidine, romifidine. I wouldn't use xylazine in the management of a surgical case. There's some evidence that it promotes uterine contraction because of the alpha-1 effects. So that's about the only thing I'd do differently.
A gente gostaria de agradecer a presença de todos e também do pessoal que assistiu pelo nosso canal do YouTube e relembrar que tem seminário toda quinta-feira ao 12h30 aqui nessa sala. Obrigada.
It's really nice to see this different crowd. São pessoas que nunca viram assim, né? Very much. I thank you for, because we had a problem with our projector, and then thank you for the rapid response team. It's a Dennis TV set. The rapid response team.